So, treatment of opioid-induced constipation. So, nearly most of the patients experience constipation, and please remember that failure to prevent constipation results in the non-compliance with the opioid therapy. So, the preferred treatment is prevention. So, what we can use for opioid-induced constipation, that is catharatics. We can use catharatics, and we can also, that is Senna 2 tablets and stool softeners, or consider first line therapy. And for refractory cases of opioid antagonists or other therapies such as lubiprostone should be considered. And methyl naltrexone is the best studied opioid antagonist for use in the refractory opioid induced constipation. It reverses the opioid induced constipation by blocking the peripheral opioid receptors, but please remember it will not block the central receptors. Methyl naltrexone blocks the peripheral receptors, and it has been shown to cause laxation within 24 hours of administration. As with the use of the opioids, about third of the patient using methyl naltrexone experience nausea and vomiting, but unlike opioid usage, tolerance usually develops within a week. Therefore, when one is beginning with opioid, an antiemetic such as metoclopramide or serotonin antagonist is often prescribed prophylactically and stopped after 1 week. And olanzapine has also been shown to have anti-nausea properties and can be effective in countering the delirium or anxiety with the advantage of some weight gain. And drowsiness, a common side effect of opioid, also usually abates within a week. And for refractory or severe cases, pharmacological therapy should be considered, such as psychostimulants, dextroamphetamine, methylphenidate, and modafinil should be given. And modafinil has an advantage of once a day dosing compared to the methylphenidate, which is twice dosing. So remember, in case of opioid induced constipation can be debilitating, and failure to prevent constipation often results in non-compliance with opioid therapy. The preferred therapy is catharist, that is Senna 2 tablets, stool softeners such as Docusate 100 mg per oral, or laxatives are considered as first line. For refractory cases, opioid antagonists or other therapies such as lubiprostone should be considered. Methyl naltrexone is the best studied opioid antagonist for use in refractory opioid-induced constipation. It reverses the opioid-induced constipation by blocking peripheral opioid receptors but not central. And in placebo trials, it has been shown that to cause laxation within 24 hours of administration. As with the use of opioid, a third of the patients using methyl naltrexone experience nausea and vomiting, but unlike with opioid usage, tolerance develops usually within a week. Therefore, when one is beginning an opioids and antiemetics such as metoclopramide or serotonin antagonist, it is often prescribed prophylactically and stopped after 1 week. And olanzapine has also been shown to have anti-nausea properties and can be effective in countering the delirium or anxiety with advantage of some weight gain. And drowsiness, a common side effect of opioids, also usually abates within a week. And for refractory or severe cases, pharmacological therapy should be considered. The best studied agents are psychostimulants like dextroamphetamine, methylphenidate, and modafinil. Modafinil has advantage of once a day dosing compared to methylphenidate twice daily dosing.